So um, today we're going to chat about cholesterol. Okay, and probably one of the, I was going to say, is it one of the more important topics? Probably not actually, but it's a very interesting topic because everybody's heard of cholesterol, but I doubt people know that much about it. And I think most of your cholesterol knowledge is probably from the fact that you may have heard that a relative has a high cholesterol. They may be on a medication for that. Or indeed, the supermarkets have several products that are deemed to reduce cholesterol. Okay, so today we're going to chat about high cholesterol causes, symptoms, and treatments. So before we chat about what we can do about our cholesterol, we're going to chat a little bit about what it is and why is it important. Because it does get the kind of the villain label. Cholesterol's bad because we only hear really about cholesterol when it comes to heart disease, etc., etc. And it's not. It's an incredibly important molecule in the body. Okay. So it's not all bad. It is essentially just a fatty substance found in the blood. Everyone has it. Okay. And we need it to stay healthy. Okay. Every cell in the body uses cholesterol because it's involved in cell membranes. And I often say to my students that if we didn't have any cholesterol, we'd be like Lego men. Okay. We'd be really stiff. All right. So it's got a major role in cell membranes of cells. Okay. It is also involved in making bile. So bile is kind of like the fairy liquid of the gut or the GI system, the gastrointestinal system. And bile is really important in the absorption of fat-soluble vitamins, A, D, E, and K. All right. And it also has a really important role in making vitamin D and also making your steroid and your sex hormones. Okay, so that's kind of the precursor of all of those. So it's really, really important for all those things. So cholesterol is not the bad guy. It becomes problematic, I guess, when we have too much of it in our our cardiovascular system. That's the issue. Okay. So next, we're going to move on to where does cholesterol come from? 80% of it is produced naturally in the liver, and 20% of it comes from your diet or the food we eat. Okay, so that also gives you a little idea of how much your diet will affect your cholesterol. It will have some effect on it, but it's not the end all and be all. Okay, so because we only get a fifth of it from our diet. Okay, so it's made primarily in the liver. And essentially what happens when we eat, we've got two systems. We've got an exogenous lipid system and an endogenous system. And the exogenous system is essentially when we eat, we break down all our food in our stomach. It gets all mixed up into chyme, goes into our small intestine. And from there, the protein, the carbohydrates, and the fat all get broken down and absorbed. And the fat that is absorbed is packaged into big fluffy particles called chylomicrons to begin with. And these big fluffy particles have got cholesterol in them and different types of fats and protein, etc. And they get tweaked along to the liver. And then in the liver, they get stripped down into the components. And that's how we get some of our cholesterol from our diet to the liver. And then we've got the endogenous pathway where the liver is busily making cholesterol. Okay, and it makes something called VLDL, very low density lipoprotein, which eventually gets converted to low density lipoprotein. So I'm now chatting about lipoproteins. Why am I chatting about lipoproteins? Sorry, give me 2 seconds. So lipoproteins, so essentially, because cholesterol is a fat and your blood is essentially aqueous, mainly water, it wouldn't normally mix. So in order for cholesterol or any lipid to be transported around in your blood, which is mainly water, it has to bind to protein. And these proteins are called lipoproteins, and lipo is just for lipid. Okay, so fat proteins are lipoproteins. And the reason why I'm mentioning lipoproteins is because that's how the different types of cholesterol have been named. So if you have an issue with your cholesterol, or you've ever spoken to a doctor about cholesterol, whether it's your GP or someone at the hospital, they've probably chatted to you a bit about two types of cholesterol, HDL and LDL. And HDL is high density lipoprotein, and LDL is low density lipoprotein. So what I often do in clinic is I'll put cholesterol at the top of the page, and then I'll do an arrow from one side and write HDL, and then an arrow to the other side, which is LDL. And the HDL is at the moment deemed to be good cholesterol. I say that for commas. All right, good cholesterol. Why is it deemed to be good cholesterol? At a certain level, your HDL is believed to bring cholesterol from the periphery, from your arteries, way out in your body, back to the liver. Okay, so it's supposed to be doing good. So it's deemed to be good in terms of cardiovascular health. It's not quite as simple as that. So if your HDL is between 1 to 2 millimoles per liter, which is the units that we measure these lipids in your blood, and we'll get on to the blood test in a wee minute, it's deemed to be healthy. If it's less than 1 millimole per liter, the HDL is deemed to be less healthy. And the population we would often see a lower HDL would possibly be diabetics. Okay, they often have a low HDL or less than 1 millimole per liter. However, it's not as simple as that. We now believe that people with higher HDLs, possibly more than 2 millimoles per liter or above that, it may not be as cardioprotective. So it's kind of a J-shaped curve. Okay, so you've got an element of protection between 1 and 2 millimoles per liter, less than 1 millimole per liter, not as well protected, and above 2, possibly not. But that's all really current research that's going on. There's nothing set in stone about that. I don't really spend a lot of time in HDL. In fact, I very rarely chat to HDL to my patients. And the reason for that is we can't do anything about our HDL. We do not have a drug that helps our HDL significantly. We can alter it a little bit with lifestyle, and I'll come back to that. But there's nothing we can really do about HDL. So your HDL is your HDL, I would suggest. The one incidence where we often see higher HDLs is if you are a habitual drinker. If you take on board quite a significant amount of alcohol, you'll often find to have a high HDL or a higher HDL. However, we do not condone a heavy intake of alcohol, just obviously to push your HDL up because of all the other issues, the havoc that the high alcohol intake will be having on your body. Okay, but that's just a caveat. Sometimes we can kind of, if we know if somebody's quite a large drinker, I'll look at their lipid profile and say, yeah, their HDL is higher, and that's probably why. But I think the HDL story, well, it's been going on for years, but it's still evolving. I guess in 5, 10, 20 years, when I'm long out of the game, we'll probably know what HDL is all about a bit more. Okay, so I'm not really going to chat about HDL anymore. The more important one from my point of view and from cardiovascular risk is your LDL, low density lipoprotein. And this is the one we get from our, basically the chylomicrons are stripped down and the LDL will be transported back to the liver. And then in the liver, we make VLDL, very low density lipoprotein, and then IDL, intermediate density lipoprotein. And I wouldn't be writing any of this down because I don't chat about any of this to any of my patients, okay? The thing you need to know is the liver makes LDL. Okay, it starts off with these building blocks and it eventually makes LDL. So what's the problem with LDL? LDL, low density lipoprotein, is the one that is laid down in your arteries as fatty plaques. Okay, so that's the big thing about LDL. So if you can remember last week, or when I was chatting about cardiovascular disease and heart attacks and strokes, the fatty plaques, which you can call them atheroma if you want. The process is atherosclerosis, but I'm all for the fatty plaques. Okay, so the fatty plaques contain LDL. And when you have the buildup of your fatty plaques, this can obviously lead to cardiovascular disease. And by that, I mean coronary artery disease, where you can have a blockage in your arteries in your heart and you can have a heart attack. Or if it happens in your head, it's a stroke. Or if it happens in your leg, it's peripheral vascular disease. Okay, so that is one of the main components of the fatty plaques is the LDL. Okay, now what happens to the LDL? So essentially, LDL in your circulation is taken up by blood cells called macrophages. Okay, doesn't really matter what they're called. When the macrophages become full of LDL or full of fat, essentially, they are then called foam cells. And these are the foam cells that are laid down to form fatty plaques. And the fatty plaques, again, we start laying these down possibly in the Western world in our early 20s, and they build up over time. And some people will have problems with them earlier rather than later, depending on their genetics, depending on their cholesterol level, depending on their lifestyle in terms of exercise, diet, smoking, etc., etc. Smoking plays a huge role in the laying down of these fats because smoking actually oxidizes the LDL. And if the LDL is oxidized, it is more readily taken up by the macrophages to form the foam cells to get laid down as fatty plaques. Okay. Now, before we get a blockage, we've spoken about this before, we get some warning signs when we're having problems with our arteries and they're getting kind of filled with fatty plaques. So in terms of your heart, can anybody remember what happens or what can happen? Presumably, if you're quite lucky because it's a warning sign, what do we call the symptom or the thing that happens before you have a heart attack, or it can happen?
Angina.
Yeah, so angina, so you can get chest pain, okay? And it's not full blockage, it's possibly come on because you've exerted yourself. And angina is the pain that's central, feels like a pressure and may radiate down your left arm. And then in terms of a stroke, you can have a mini stroke, a TIA, same kind of thing. You have a little blockage, but the symptoms resolve within 24 hours. And then in your legs, we haven't really spoken about this, but peripheral vascular disease. So you'll get claudication in your calf muscles. And what happens is if you've got some narrowing of your arteries due
Go
to,
ahead, see if I can chase down this
due to
raptor.
your buildup of fatty plaques, when you walk, if you'll walk a certain distance and you'll get pain in your calf muscles and you'll rest for 5 or 10 minutes, sit in a park bench and it'll go away and then you get up again, start to walk. And as the claudication, as the blockages get worse or the furring up of the arteries gets worse, you'll be able to walk less or less. And then eventually you can actually get the rest pain at night because your circulation's quite poor. And that's all got to do with decreased blood flow and therefore decreased oxygen delivered to the tissues, and if it's your heart, your head, or your muscles and your legs, and that's called ischemia. Okay, so that's essentially a little bit about cholesterol. It is made primarily in the liver. Some of it we get from our diet. And we've essentially broken it down into two types, HDL and LDL. LDL is the bad one that's laid down in your arteries. HDL is supposed to be cardioprotective to an extent. Anybody get any questions about that? No? All good. Right. So let's chat a little bit now about what things can cause a high cholesterol or change your cholesterol. So again, I split this into non-modifiable and modifiable causes of having a high cholesterol. So non-modifiable. Anybody get any suggestions?
I would say your family history, genetics, that sort of thing. You can't really change that.
Yep. So your genetics, you may have a predisposition to something called familial hypercholesterolemia, and I'm going to come back to that at the end when we round things up.
Could it be your age?
Yeah, so your cholesterol often goes up with age, okay? And I get a lot of referrals to clinic of the peri or postmenopausal females at 55 or even 60. And unfortunately, they haven't had, if they'd had a cholesterol done 20 years earlier, it would be rather straightforward because I could say, well, the cholesterol is okay 20 years ago. It's because they've gone through the menopause. Your cholesterol often goes up with age. That'll be due to two things. It just goes up with age. It also can go up with a change in your body habitus if you've got more fat around your liver. And also we know now, there's been a lot of research recently around females. We know it goes, your cholesterol and particularly your LDL goes up through the menopause. Okay, so if you often get your cholesterol done at 55, it'll be different than what it was maybe when you were 40. All right. And again, in terms of gender, we know that that happens around the menopause for females more than obviously males. Ethnicity is also important. That's something else you can't change that may affect your cholesterol. Modifiable, what are the kind of modifiable things that we can think of when it comes to cholesterol?
Diet,
Diet, yep,
exercise,
yes,
medication,
yep, and your weight as well, okay, because that can obviously affect what's going on with your liver, especially if you've got weight around your abdomen, okay. So what causes a high cholesterol? Many different things can cause a high cholesterol. Some can be controlled by lifestyle. And therefore, if we modify that lifestyle, we can lower our cholesterol. Some of them cannot be controlled by lifestyle, especially if it's a genetic reason. In terms of genetics, the two main things that I would review at clinic would be familial hypercholesterolemia. So familial hypercholesterolemia is the most common metabolic disease, inborn metabolic disease in the UK, Europe, and the States, I think, okay. It's got a prevalence of about 1 in 200, which is shocking because we're not actually very good at finding them anymore. About 15, 16 years ago, when I was a junior doctor in metabolic medicine, we found quite a few people when we were screening them. That seems to have all slowed down for whatever reason. But you can have a genetic predisposition, and familial hypercholesterolemia is an autosomal dominant problem. That's how you inherit it. So you only need one gene from one of your parents. So if one of your parents has got it, you have a 50% chance, a 1 in 2 chance of you getting it. All right. And I had a young patient recently who's been referred at 27 with a LDL of 10 and a total cholesterol of 12, and we'll come back to what your levels probably should be around, okay? So FH, everybody should be aware of familial hypercholesterolemia. Familial is just in the family. Hypercholesterolemia is high cholesterol. How would you know if you've got FH? Couple of things you can look at. You can look at your cholesterol levels. So you will need a total cholesterol more than 7.5 millimoles per liter and an LDL more than 4.9 millimoles per liter. You also need to have a significant family history of heart disease, and significant is really important. Most people in the west of Scotland will have a family history of heart disease. It doesn't mean it's a significant one. So significant, I mean a first degree relative with heart disease under the age of 60. So that's your mum, dad, brothers or sisters, or a second degree relative such as your grandparents, etc., under the age of 50. All right. Whether they've had an event or whether they've had a very high cholesterol. The waters get muddied a wee bit because, as I say, I get referred loads of females who are peri or postmenopausal. They haven't had previous cholesterol levels done. And also, you've got to remember our other lifestyle choices. Some people will have had a heart attack or a stroke at the age of 50 because they were overweight, smoked, and drank as well, which kind of muddies the water a wee bit. But you should definitely discuss any significant family history with your family physician if you're found to have a high cholesterol, okay? There are other people that we test. Up in Scotland, we're allowed to genetic test for familial hypercholesterolemia, which is quite good. It determines whether you have a mutation or not. But people still can have very high cholesterols but not have be found to not have a mutation for familial hypercholesterolemia. And we often say they're polygenic. So that just means they've got lots of different genes that result in a high cholesterol. And you can't test for that. Okay. Let's chat a little bit about controllable factors in terms of a high cholesterol. What kind of things can we do? We've already alluded to diet, weight, and exercise. So let's chat a little bit about diet, just from your day-to-day knowledge. What kind of things do you think you should or should not be eating?
high fat foods,
High fat foods. Yeah, and it's important to kind of differentiate between the fat. in the 80s or 90s, there was a correlation between fat in the diet and heart disease. And that made the sweeping statement that everybody should be low fat. As a result of that, everybody went low fat, but we went high carbohydrate. And by that, I mean high refined carbohydrate, and then ultra processed foods kind of came into play. And that's not great. So now we know you've got to kind of differentiate between the types of fat. So the fats that aren't good for your heart, and we still know aren't good, are saturated fats. Can anybody give me an example of where we would get saturated fats from?
Butter, anything that's hard at room temperature.
Yeah, so butter, lard, dairy products. The thing I always think of, because I live in the west of Scotland now, is kind of pastries and pies. I kind of think of that pie, but the pie you kind of get at a football match. You know, the pork pie and cased with the pastry with more lard just on top, essentially. So pastries, pies, processed meats, so burgers and sausages, etc., will have lots of saturated fat in them. Coconut oil, you've actually got to be quite careful with, because it has a high level of linoleic acid, which can increase your LDL, okay, and dairy. So the other fats that are deemed good for your cardiovascular health are the unsaturated fats. So those would be nut oils, and you get those nut oils, and then avocado as well are deemed good. Oily fish will contain your omega oils, which are good for your heart health. And then you've got your I think in terms of cooking oils, extra virgin olive oils deemed the most healthy. Okay. There was an episode where trans fats very early on, I think it was in the 80s, was linked to these were artificial fats. Trans fats were unsaturated fats and vegetable oils, and they are a definite no-no. And the FDA came down on that very, very quickly. I think there are some very low levels of trans fats still in foods, but they shouldn't be high levels at all. They were essentially banned. Okay, so trans fats aren't good. So saturated fat, we don't want very much of. And if we're going to have fat, unsaturated fat in nuts, avocado, oily fish, etc. Okay, but again, you'll know how many nuts can you eat in terms of if you're looking at your calorie intake. Okay, nuts are very good for that. They've got good fiber in them. Some of them have, like your walnut that has the kind of skin on them, are good with polyphenols and things like that. They're all good for your gut microbiome. But unfortunately, sitting down and eating a whole bag of nuts, although that would be quite nice, is not necessarily a good thing, I would suggest. Okay. In terms of, those are the things you should avoid with cholesterol. One of the websites you can look at, which is really good, is Heart UK, okay, cholesterol charity, and it will tell you all about cholesterol, and it will tell you all about, it's basically a whole food diet, I would suggest. So whole grains, you definitely want brown instead of white. And again, it's back to the basic rules. I say this all the time: eat the rainbow. The more vegetables and all the different colored vegetables you have, and the same with fruits as well. You won't go wrong by eating too many vegetables, and lots of different types of vegetables, and making that the majority of your plate as opposed to the refined carbohydrate. Okay, so not being active enough. And I've been learning about this week in my lifestyle course, the difference between activity. So actually being active as opposed to being sedentary, and they're not the same thing. So I could go to the gym 5 days a week and do 5 hours of gym work, whether it be cardiovascular or resistance training. But if I sit for the rest of the time, you know, if I get up, literally walk to my desk, sit for 8 hours a day, and do my 1 hour of gym in the evening or my 1 hour of gym at lunchtime, that is not as good as me going, say, to the gym 3 times a week, but making sure I get sufficient steps and getting up and moving around throughout the day. It's all about moving and decreasing your sedentary activity. So being active is really important. Being active, increasing your exercise and moving more, has the ability to increase your HDL. Okay, it's never going to put your HDL through the roof, so do not panic, but it can put the HDL in the right direction, can decrease your LDL. That is because exercise increases the LDL uptake by the liver. It can also help, it can obviously help with weight reduction, which will in turn result in a decrease in abdominal or visceral fat, which is very important, removing fat from your liver. It can also help with your blood pressure, which in terms of cardiovascular risk is very important. And it can also decrease your type 2 diabetes or your insulin resistance risk. So those are all really important reasons why you should be moving more in terms of both formal exercise and also just being active throughout the day. Now, in terms of where your weight is, i.e. where the fat is, so your body fat, which is around the abdomen, we've spoken about this before, there's a little bit under the skin, your subcutaneous fat, but a lot of it will be around your liver. And your liver is the big organ that processes your lipids. Okay. Now it's involved in producing cholesterol, but the other lipid, which we're going to chat about next week, triglycerides, are really affected by how your liver is. So if your liver is full of glucose and your glycogen stores are full and your glucose stores are full, the rest of the carbohydrate will get converted to triglycerides. Okay, and these triglycerides will eventually fall out into your blood and we'll be able to measure them. And I saw a gentleman at clinic yesterday with this very problem. Okay, so we can now measure his triglycerides in his blood, and your triglycerides increase your risk of cardiovascular disease and also pancreatitis, but we're going to cover that next week. This truncal weight also increases your insulin resistance, all right, and leads to you heading into the going from having normal glucose levels to being pre-diabetic to being diabetic. And again, that all increases your cardiovascular risk and can also, if you're insulin resistant or poorly controlled diabetic, that can have effect on your cholesterol and your triglycerides. Okay, so they all tie in together. It's all they're all interrelated. If you had a spider, you know, if you had a diagram, there'd be arrows pointing everywhere. Okay, so they're all interrelated. The other thing in terms of cholesterol, it doesn't affect your cholesterol level per se, but the other thing that is a no-no I've written here is smoking. Okay, and the reason why smoking is a no-no is because the smoking accelerates that process of atherosclerosis. And this is particularly important in your legs, okay? When if you ever have an issue with peripheral vascular disease and you go and see a vascular surgeon, I am sure the first thing they will literally ask you before you walk through the door is, do you smoke? Okay, and for whatever reason, smoking affects the legs a lot. It affects your heart and it affects the plaques in your brain as well. But peripheral vascular disease is really affected by smoking. So if you go to get seen by a vascular surgeon and they do a bit of replumbing or fix something or do whatever they do, and you continue to smoke, you will literally just clog it up again very, very quickly. Okay, and that's the same with your coronary arteries. If somebody puts a stent in to clear that blockage and you continue to smoke, or if you get a bypass, you get a coronary artery bypass graft put in and you continue to smoke, you will literally just clog it up again and you'll be back to square one. Okay. Any questions about any of that?
No.
Okay, so the things you can't control are age. You're getting older. Okay, it is what it is. You can control certain things though. Yes, my LDL. So I was 47 when I started TSD 4 years ago now in January. And at that stage, I was circling the perimenopausal drain. I'd done loads of reading about it. I've read about HRT. I've read about lots of different things. And the thing that really came to me was the fact that I had to change my lifestyle quite considerably. And I've been tweaking it ever since. And I continue to tweak it most days. My theory was, yes, your LDL and your cholesterol is going to change going through the menopause, as are your symptoms, your menopausal symptoms. But if you can tackle a lot of it just by lifestyle, you will offset some of that. Okay. So I can't control my age. It's going to go up. I can't control the fact that I'm going through the menopause, but I can do as much as I can lifestyle wise to kind of tackle that. Okay. You also can't change your ethnicity, and you cannot change your genetic predisposition. You can choose your friends, but you can't choose your family. Okay, if you've got familial hypercholesterolemia, you've been diagnosed with that, the chances are you have been put on therapy to lower your cholesterol, because we know that if we get your cholesterol, your LDL down in particular, and we do this for many years, your lifespan can be the same as anybody without familial hypercholesterolemia. And the young fella I was speaking to this week, he's only in his 20s, that's been diagnosed with it. And it is a bit of a blow, okay, because he'll be on lifelong medication. But if it hadn't been discovered, he could have maybe dropped dead of a heart attack at the age of 40. Okay, so you kind of have to look at the silver lining. All right, but there are just some conditions that you do need to take medication for. So signs and symptoms, unless you've had angina or a mini stroke or a stroke or a heart attack, there are no symptoms of having a high cholesterol. It's a little bit like blood pressure. Blood pressure usually goes unknown unless you get it measured, not unless it's very high and you start having problems with possibly headaches or dizziness or whatever. All right. But cholesterol is the same. You have no idea what your cholesterol is doing. This young gentleman I saw recently had no idea what his cholesterol was, because why would he ever get it measured? Young, slim, fit man. Okay. So the idea is you can't feel it, so you need to get it checked. Because it's one of those hidden risk factors that you won't know about until you get it measured. So how is it measured? It's a simple blood test. Many of you have probably had this done. A simple blood test you can get done by your GP, or you may get it done in the hospital, depending what you're in hospital for. We break down, in the health board I work in Scotland, we do a lipid profile, which gives you your total cholesterol. It gives you your HDL, your LDL, and your triglycerides. Okay. Now, the LDL is not measured. It is calculated, and I'm not going to go into that because that's quite a complicated reason for that, but it is measured, or it's calculated. All right. So it will only be calculated if your triglycerides are below a certain figure. So sometimes you will not, if you get high triglycerides, you may not get an LDL result. But if your triglycerides are okay, you should get an LDL result. What do I chat about to my patients? Because everybody always asks, what level should your cholesterol be at? And it's not quite as simple as that. In years gone by, they showed in the 80s that having a total cholesterol more than 5.5 probably increased your risk. But we've progressed since then because we now have risk calculators that we use. Okay, the one that I commonly use in Scotland is Assign. Assign 2 is about to come out, so I'm not using Assign at the moment because they're just about to release Assign 2. The one that's in NHS England, not too sure what they use in Wales. Presumably Northern Ireland probably uses the NHS England one. It'll be QRisk 3. You can find these online. You can just Google Assign 2. Well, don't Google Assign at the moment because you'll not find it, but QRisk 3. And if you go in and have a look at that, you can see that it asks all sorts of stuff. So what does it ask? It asks your age, and it's really weighted by age. Okay, your risk goes up with age, irrespective of any of your other markers. The same way, if I have a young person, it will possibly falsely give me a low risk because of their, if I put in the age of 22 versus 62, the risk is going to definitely, it's very weighted for age, which is understandable because you are more at risk of having heart disease at the age of 62 than you are at 22. It will ask you for whether you're male or female, your ethnicity. Oh no, they don't cover your ethnicity actually, just male or female, postcode. The Assign was one of the first ones that took in your postcode because it takes social deprivation into account. It will then ask you all sorts of things. It will ask you about blood pressure. It will ask you about cholesterol. It may ask you about your total cholesterol and your HDL, or the cholesterol to HDL ratio. The QRisk asks you about height and weight, which is really good because it involves the BMI. The previous Assign didn't ask about BMI. I'm hoping the new one will. QRisk then goes on and asks you all these different things about whether you've got a family history of heart disease, diabetes, or whether you've got X, Y, and Z. It literally asks you right down to the color of your underwear. It's a huge, huge questionnaire. And then it will give you a risk for over your next 10 years of the chances of you having a heart attack. It gives you a picture. So it gives you a little box with 100 little yellow smiley faces, and it's a little purple sad face if that's your risk. So say your risk is 4%, it will have 4 little purple faces and 96 little yellow faces. And it can give you your heart age, your predicted heart age, which is not necessarily the same as your age. Okay, so that's quite useful. Most of the guidelines, NICE, etc., suggest it used to be when your risk was more than your sign was over 20, your assigned score more than 20, it's now over 10. So if your risk is over 10% for the next 10 years, you will be offered therapy, or definitely lifestyle advice and therapy. Okay. So there's no real figure for whether I would suggest your cholesterol is high or not. Definitely if your LDL's 5 or above, now that's your LDL, not your total cholesterol. If your LDL's 5 or above, and if your total cholesterol is more than 7.5, that needs to be discussed. But I think now we just don't turn around and say, well, your total cholesterol has to be less than 5. That's not what we do. You have to be risk assessed depending on your other factors. And there's loads of things that to take into consideration. The assigned score doesn't take into consideration body mass index, but I will often chat to my patients, and they may be on blood pressure medication. So their systolic blood pressure I put into the risk calculator may be well controlled, but that's because they're on 3 meds for their blood pressure. So I will take into consideration, you know, if they're overweight, and if they're insulin resistant, and if they're, you know, on blood pressure medication, that changes their risk profile, and you can decide whether they should go on medication or not. In terms of just lifestyle, eat a healthy, balanced diet, low in saturated fat, get active, stop smoking. Medication wise, does anybody know of any of the medications we use to lower cholesterol? I've alluded to these at the beginning.
Statins.
Statins, yep. Okay. So what do statins do? Statins can get a good rap or a bad rap. I think for everything positive you say about statins, you see 2 things negative for them, particularly in some of the newspapers, which will remain nameless. All right. They do what they say on the tin. Okay. They lower your LDL cholesterol and they decrease your risk of heart disease. We use statins for primary prevention, and by primary prevention, I mean someone who's got a high cholesterol but hasn't had an event yet. Okay. And again, you can use risk calculators to determine whether you need a statin or not. However, in secondary prevention, I think they're definitely recommended. Okay, this is where they really find their place. If you've had a heart attack or a stroke, well, if you have I always chat to my patients and say, if you have a heart attack or a stroke tomorrow, you'll walk out on a very high dose of atorvastatin, 80 milligrams with no questions asked. Okay, now, not everybody can tolerate statins. Not everybody wants to go on medication. So in terms of primary prevention, you should always assess your lifestyle first, I guess, before you go on medication. If you've got a genetic predisposition, I would suggest you take good health advice regarding going on statin therapy. How do they work? So essentially, if you can imagine a liver cell, and I often draw this in clinic, so I draw a circle, a liver cell, and I show the little building blocks that make up statins. So you start with a couple of Lego blocks, you move along, and they add on, and you get cholesterol at the end of that line. Okay. Statins block part of that pathway. If you block your liver cell making cholesterol, it results in taking more cholesterol, LDL, into the cell. So the machinery inside the cell puts more receptors up on its cell surface and just brings in more LDL into the cell. And the more LDL that the liver cells are bringing into the liver cells, the less LDL that's in your arteries. And the less LDL that's in your arteries, the less LDL that can clog up your arteries. That's essentially how statins work. Okay. There are 2 or 3, 4 different types of medication now for lowering your cholesterol, but I'm not going to go into those today. But statins are the mainstay of treatment. And again, as I said, very good evidence for secondary prevention when you've had an issue. Whether you want to use them for primary prevention or not has to be a discussion between you and your physician who's you're having the conversation with. Okay. And primary prevention, we advocate them with people with obviously a genetic predisposition, particularly familial hypercholesterolemia, because we know people with familial hypercholesterolemia with high LDL levels will have heart disease 10 or 20 years earlier than the general population, because they can be sitting with an LDL of 10 from their mid-teens. Okay, which is very high. All right. Okay, so essentially, things to remember from today. Cholesterol is really important in the body. We use it for all sorts of things, cell membranes, hormones in the body, your sex hormones, etc., making vitamin D. It's a precursor for vitamin D as well. we get 80% of it made in the liver, 20% from your diet. So that's interesting. So I've had some patients, I had one gentleman several years ago now who decided to go vegan for 9 months. And I thought, well, that's quite interesting. This will be N equals 1. It's not a randomized controlled trial by any stretch of the imagination. It's an observational study of N equals 1. And he had a high LDL. He did not have familial hypercholesterolemia. We tested him for that. And he was a vegan for 9 months. And his LDL did not budge. He was also a runner. So his LDL was his LDL. All right. So that was possibly a polygenic cause for that we can't test for. So your diet, it depends what your diet, I think it depends what your baseline diet is. I would imagine in the guy that I'd spoken to, his baseline diet was pretty good to begin with. So tweaking it wasn't going to make that much difference. However, if you have a fairly, if you have a diet that's affecting, your cholesterol and you've got high saturated fat and you're not moving very much, et cetera, and your lifestyle's not quite what it should be, I would imagine you can have a bigger impact. And definitely I would never treat anybody with one cholesterol profile. You should have at least 2. Okay. All right. Yeah, so the things we want to do is we want to look at a whole food diet, watch your saturated fat intake. We want to move more. I think that's something that we don't really relate to cholesterol very much. Okay, activity is important, and weight around our abdomen is very important because of our liver. Okay, and smoking is a no-no. All right. Again, not to do with the cholesterol level, it's just what it does to our cholesterol in our arteries. Okay, any questions regarding any of that? That's quite a lot of information to take in. But it's kind of a whistle-stop tour of all things cholesterol. Okay.
Very good.
Thank you.
Anybody get any?
Can I ask about red meat? Is that okay to consume, or does that affect your cholesterol?
No, yeah, red meat's fine, but again, it depends. In terms of if in TSD, when you started, you were probably suggested to have lean red meat. And I'm always the one, if I'm ever going to have a steak, looking at the back of the packet to see, whatever. And also red meat wise, if I buy mince, I go for the 5% or less as opposed to the 10, you can get up to 20% fat. So yeah, red meat, yeah, it just depends on the saturated fat in it. I don't consume a lot of red meat, but that's not necessarily because of my cholesterol. That would be more just because of, I don't think you should be having too much red meat. And that's probably more from a gut point of view. But yeah, no, red meat's fine to eat. But yeah, just not and I think the issue with red meats would be more if you're doing the processed burgers and I've actually started, if we do have burgers at home now, I buy the mince and just make the burgers myself. And that's essentially just so that there's not a load of other stuff added in, which you can find with, even the good burgers in the supermarket can have lots of other stuff in them, which I don't necessarily. So I just buy mince and make burgers with that if I want to. But yeah, no, red meat's okay, but again, it'll depend on the cut and the saturated fat content. But again, you shouldn't. Well, presumably you won't be eating a whole lot of it. Right. Okay, so that's us. So next week it's all about triglycerides, which people have mostly heard of cholesterol, maybe triglycerides not as much. We'll have a chat about triglycerides next week. Okay, well, thanks very much for joining me this morning.
Thank you very much.
No problem, Babs.
Very
Thanks for
good,
joining
thank
us,
you.
and I look forward to seeing you all next week.
Thank you.
Okay, have a good week.
Bye.
Take care, bye.
Bye, everyone.